Obsessive-compulsive disorder is often introduced as an anxiety disorder, but a mechanistic understanding begins elsewhere. The core issue is not anxiety alone. It is a failure of action selection and termination within specific brain circuits. To understand this, we start with the corticostriato-thalamocortical loop, often called the CSTC loop. This network links the orbitofrontal cortex, anterior cingulate cortex, ventral striatum, and medial thalamus. Functionally, it acts as a continuous evaluator, asking a simple question: should I keep going or should I stop? In OCD, this stopping function becomes unreliable. The failure mode is not simply heightened worry. Instead, there is an inadequate stop signal combined with an excessive internal error signal, often experienced as a feeling that something is not just right. Mechanistically, this reflects a relative dominance of the direct pathway with insufficient indirect pathway inhibition, leading to persistent thalamic feedback to the cortex. The result is action persistence. Thoughts and behaviors continue even when the person recognizes they are unnecessary. Obsessions emerge from exaggerated error signals generated by the orbitofrontal and anterior cingulate cortices. These signals convey a sense that something is incomplete, unsafe, or incorrect. Importantly, obsessions are not fixed beliefs. They are intrusive error messages that fail to resolve. Insight remains preserved because reality testing is intact, which helps distinguish OCD from psychotic disorders. Patients usually recognize that their fears are excessive, yet the internal alarm does not shut off. Compulsions develop as attempted corrective actions. Washing, checking, repeating, or mental rituals temporarily reduce the error signal. That brief relief reinforces the behavior through learning mechanisms. Over time, control shifts from goal-directed action to habit-dominated responding. The person is no longer performing rituals because they logically believe in them, but because the nervous system has learned that repetition reduces internal tension, even if only briefly. OCD also recruits several secondary systems. Threat circuitry involving the amygdala adds urgency and dread, making the experience emotionally intense even when danger is minimal. Thalamocortical gating becomes inefficient, reducing sensory filtering and increasing awareness of thoughts or bodily sensations. Cognitive control networks become overactive, producing excessive monitoring, rumination, and mental checking. Together, these processes transform a simple error signal into a persistent disorder of action and attention. The sustaining loop can be described clearly. An error signal triggers a compulsion. The compulsion provides temporary relief. Relief reinforces the action, strengthening future error signaling. Insight alone does not break this cycle because the loop operates at a procedural level rather than a purely cognitive one. Patients may understand that reassurance is accurate, yet the internal system continues to generate doubt. A concise mechanistic formulation would be this: obsessive-compulsive disorder reflects a disorder of action termination within CSTC circuits, producing persistent error signals that drive compulsive behaviors through maladaptive habit learning, with secondary threat amplification. Clinically, several features support this model. Insight is usually preserved. Compulsions feel necessary rather than pleasurable. Attempts to resist rituals increase anxiety. Symptoms often worsen during sleep deprivation or cognitive overload, when inhibitory control weakens. Understanding OCD through this framework shifts the focus away from simple anxiety reduction and toward restoring balance within action selection, error monitoring, and habit learning systems. When clinicians conceptualize symptoms as outputs of dysregulated loops rather than irrational choices, treatment planning becomes more precise and patients often feel more understood.